Michelle, I know you're there because we were just talking. And Nogel, I feel like I just saw you, like, when was it, yesterday?
Yeah, do you know what I got on my test? Can you tell me?
Oh, I saw it as soon as you finished.
Well, she still hasn't posted.
Really?
Yeah,
Not everyone can be cool and post the grades right away.
right.
I don't know, but maybe she has like multiple classes. I don't know. I mean,
Her dog has been having a hard time, so that might be the reason.
that's all the people turn their camera on. T-Tao, I know you're there because I just heard you talking. All right. It's like everybody's so scared to be on camera and be seen, but wants to post on the gram every 2 seconds of like, come on, which is it? Either you want the attention or you don't. Just be consistent. All right, so the stuff from this week, honestly, I made it so easy for you for the finals. So if you don't, at least for this week's material, if you don't get it all right, I don't know. I don't know what to do. So one question on which of the following are cholinergic drugs. Next question is which of the following are anticholinergic drugs. Next one, what drug do you give when you're doing the Tensilon test?
Atropine?
When you're doing the test? What?
Oh, endophoninum. Oh,
yeah, good enough. The one with the E, edrophonium. And then if the patient's symptoms get better, what drug do we give? It's the N1.
Neostigmine?
Yeah, neostigmine. If the patient's symptoms get worse, what do we give?
atropine.
Atropine. Okay. For treating Parkinson's disease, we give the levodopa carbidopa. What's the purpose of the levodopa? What's the purpose of the carbidopa?
Carbidopa drives levodopa across the blood-brain barrier.
Okay, and then levodopa, what does it do once it's in the brain?
Remember, it's dopamine.
Yeah, it becomes dopamine chemically. Look, how easy are those questions? Should be 100%. What's the patient teaching for people taking Sensipar, which is the levodopa carbidopa?
Is this one it's only good for 5 years?
I mean, it may work longer, but it just, for most patients, it's going to start wearing off. So whether it's 4 years, whether it's 5 years, 6 years, for most patients, like around year 5, it's going to start, they're going to start noticing it's not working as well. What type of foods should they eat or not eat?
Foods high in protein.
Low in
Yes.
protein.
Yeah, so avoid taking foods high in protein. They can eat proteins, just like small meals consistently throughout the day, small protein containing meals throughout the day. And then there was a certain vitamin that they need to kind of avoid. Yeah, B6. You want to teach avoid pyridoxine, vitamin B6. Someone has an acute seizure. What's the first drug we're going to give?
Lorazepam.
Yeah, I'm going to give IV lorazepam. What were the 3 drugs I said to know that treat peripheral neuropathy?
V6, gabapentin, and pregabalin.
Yep. CC. IV, when you're given phenytoin, so phenytoin is one of those traditional anti-epileptic meds. They treat seizures, so phenytoin. So if you're given IV phenytoin, I gave you a couple safety things to remember. What were they?
Cardiac monitor. Patient.
Okay, I'll take cardiac monitor. So you don't want to give it, you do not want to give it fast. So you want to do it no more than 50 milligrams per minute on the IV infusion. Slower than that's totally fine. So you don't want to give it fast. You want to give it slow, no more than 50. Remember, it should have a filter. And what was the therapeutic range?
10 to 20 micrograms per minute.
Yeah, 10 to 20. There we go. Okay, so for the next anti-seizure med was the carbamazepine. So what was the thing that I said could lead to Stevens-Johnson syndrome? Or could be a sign of Stevens-Johnson syndrome?
Rash.
Rash. So that's going to be a potential sign of a serious side effect. What other serious side effects does carbamazepine have?
Pancytopenia.
Yeah, so pancytopenia meaning red blood cells low, white blood cells low, platelets potentially low. So anemia, thrombocytopenia, leukopenia, that type of stuff. What was that weird thing I said when the eyes, they kind of go like waver back and forth, showing that the brain's starting to get.
Nystagmus.
Yeah, nystagmus. So those are all the serious stuff. Which of the seizure drugs I said had the serious effect of purple glove syndrome?
Levetiracetam.
What did you say? That was pretty funny. You had like 3 drug names in one word. So phenytoin. Phenytoin is the one that can do the purple glove. Valproic acid, or valproate as it's sometimes called, can cause pancreatitis. What were the lab values I said to monitor for pancreatitis?
Lipase and amylase.
Yeah, lipase and amylase. So the drug lamotrigine with an L, lamotrigine. That was one I spent quite a bit of time talking about. It could cause aseptic meningitis. And aseptic, you should know, is like without bacteria. So that's when we start IVs, we do it with aseptic technique. When we insert Foley's, we do it with aseptic technique, meaning we're trying to do it without bacteria. We're trying not to give them an infection. So when they say aseptic meningitis, that means the brain and the lining of the spinal cord get infected, but it's from the drug itself. The drug's inflaming it, causing inflammation, pardon me, not infection, inflammation. So it's the drug itself for lamotrigine. So what were some of the signs and symptoms of the triad we talked about, the meningitis triad, and then the 2 tests you could do at the bedside to kind of confirm that they have meningeal irritation or meningitis?
For the triad, it's the fever, photophobia, and the neck stiffness.
Stiff neck, sometimes called nuchal rigidity, just so you get used to that term, nuchal rigidity. Fever, nuchal rigidity, photophobia. You'll see some resources instead of photophobia, they'll say altered level of consciousness, like the patient's kind of changing their behavior. And then Malari said the two tests were Koenig's and Brudzinski, but just describe them real simply. So you both start laying flat. Then what? Let's start with the Brudzinski. What do you do? So remember, Brudzinski begins with the B, so they can pull the back of the head so the chin touches the chest. And if when you do that, they go, ow, and then like they bring their knees up on their own, that's the Brudzinski, and that shows that meningeal irritation. And the Koenig is the one where they start laying flat, but then you get their knee. How about this? They do that, and you put their knee up at like a 90-degree angle, then you straighten their leg. If right when you straighten their leg at the knee, they scream out in pain, and then they lift their head and they scream out in pain. That's meningeal irritation. So yeah. We said giving eye drops. So we talked about giving eye drops. You're gonna have a lot of eye drops in the hospital or just in real life because a lot of people have glaucoma. They have increased pressure inside their eye. So they'll be taking eye drops the rest of their life if they've been diagnosed with glaucoma. So we said the problem was that those eye drops, especially if they're beta blockers, if they go on the eye, great, that's what we want. We want them to stay on the eye, but we don't want them to absorb into the bloodstream and then go down and get beta blockered sent to the whole body. So what was the step we took in giving the eye drop that prevents the systemic absorption of the drug?
You press on the puncta.
For how long?
A minute.
Yeah, like 30 seconds to a minute. So yeah, you hold pressure on either. Some books or some tests will say nasolacrimal duct because naso, which is nose, lacrima. Remember, to lacrimate means to make tears. So the tear duct, they'll say the nasolacrimal duct. Some books and some tests will say the puncta because this is also called the puncta. So you just hold pressure there. Some books say 30 seconds, some books say 60 seconds, whatever. It's hold some pressure there for a while so that it doesn't get absorbed systemically. And then I put this one on this week's test because remember for this week's quiz, I had one extra question I threw on there since everybody has trouble with cardiac. What do you need to check before you give enoxaparin? Enoxaparin, not the respiratory rate.
PT and INR.
Nope. So what other drug ends in that same ending?
Heparin.
Yeah, heparin. So what do you need to check before you give the drug?
You need 2 RNs as a witness.
Nope.
APTT.
PTT.
Yeah.
Nope.
Well,
Platelet count.
Yeah, the platelet count. So the concept here is that both heparin and enoxaparin are both anticoagulants. They work very similar. Heparin is full-strength heparin. Enoxaparin is a low molecular weight heparin. The concept is simple. Remember I called enoxaparin like a watered-down heparin? So heparin is, when do we give it? We give it when someone is having a heart attack, when someone is having a stroke. We give it when someone is having a pulmonary embolism. In other words, they have a problem. We're treating it with heparin. So for heparin, basically all the answers you gave are right. Heparin needs 2 nurses to make any dosage adjustments. You need to monitor APTT. You hold for platelets less than 100,000. And heparin, is super, super big bleeding risk. The enoxaparin, who did I say we gave that to? I said we give that to pretty much everybody in the hospital to prevent DVTs. So since we're giving it to everybody in the hospital, it's a watered down version of heparin. So we don't monitor we don't need to monitor anything. All we do is just make sure that the platelets are above 100,000 and then we give it. We don't need 2 nurses. We don't need whatever. So heparin, remember, heparin is usually, when we're talking about heparin for like those coagulation things like stroke, heart attack, we're giving it IV infusion. Enoxaparin is that subcutaneous injection. So then next question would be, what's the proper administration of enoxaparin? How do you do it?
2 inches from the umbilical in the sub-Q.
Okay, and? ¿Qué más?
I don't know.
So what was in the syringe that was different from, because remember that it comes in a pre-filled syringe. What was different from that from all the other drugs?
It had bubbles, so you don't want to like get the bubbles out. You want to leave.
Yeah. So the bubble is not meant to be, it's not an error that the bubble is in there. The bubble's in there on purpose. So you're injecting the bubble into the patient. So take the umbilicus or the belly button, go 2 inches away, inject it deep sub-Q, inject the bubble into the skin, and then the needle will self-retract. And you can just hold very gentle pressure. You don't rub it or do anything crazy like that. Okay. So that was it for this week. So for this week's stuff, that should make you less stressed out, because for this week's stuff, you should get all those right. Right? All right. I'll go over super like lightning speed, kind of a final review. I haven't made the final yet, so most of the stuff will be on there though, almost guaranteed. So I'm gonna talk fast. So for those of you recording, I'm gonna talk fast. You may need to slow down your, you know, you go to YouTube and you like speed up the thing, you need to slow it down to like half speed. All right. So select all the apply on the abbreviations for the drugs that should not be crushed. You need to know the brand name versus generic name. You need to know the pharmacokinetics, you know, about, remember, blood-brain barrier. Some drugs can't cross the blood-brain barrier, so they don't get absorbed where we need them. You need to talk about what is the effect of decreased liver function? What is the effect of decreased kidney function on drug absorption and distribution? What is the effect of having a drug that's highly bound to protein in the patient? What happens when a drug is bound to protein? Can it be used from the body? Metformin, how does metformin and doing stuff with the kidney, how does that interact? Potassium in the kidney, how do those interact? What is the MEC? What is onset time? What is peak time? What is half-life? Loading dose versus maintenance dose, what is the difference? What does the word agonist mean? What does the word antagonist mean? What does tachyphylaxis mean? Adrenergic versus cholinergic. You guys should know that down cold by now, hopefully. I'm hoping. When to draw peak, when to draw trough. Insulin times, the peak onset duration. Which is the insulin that doesn't have a peak? When do you give rapid acting insulin in relation to meals? What insulin do we use when somebody is in DKA? What med do we take for hypothyroidism? When do we take it? What are the adverse effects? Be able to recognize the adverse effects. Remember, because like the patient's not going to tell you, I'm feeling palpitations, Nurse Jones. No, they're going to say, I got this funny like fluttering feeling in my chest, right? Vasopressin, which is basically synthetic ADH. What were the safety concerns about that? What lab value do you monitor for that? Steroids and benzos, I'm telling you, know everything right now. Steroids, benzos, and digoxin. You should leave this term knowing everything about those three. Glipizide, what do we say not to take it with? The H2 receptor antagonist. So the antihistamines, there's H1 and H2s. Remember, the H2s are for stomach acids. So the H2s, remember to recognize the names. The The PPIs, be able to recognize the names. That's easy. You just look at the ending. Signs and symptoms of hypoglycemia versus hyperglycemia. Or some of the safety considerations with methotrexate. If patients taking cyclosporin, what should they not take also? So what's contraindicated? Patients should not be taken if they're on cyclosporin therapy. What's the adverse effect of cyclosporin? Which drugs cause respiratory depression? Propofol, what do we say the safety considerations were? So for that, think tubing, allergies, how long can it be hung up for? NSAIDs, what are some of the bad adverse effects? So you could think bleeding and stomach things, but then what are some other, what would that look like? For example, like tarry stool. What do we do for aspirin overdose? What do we do for acetaminophen / Tylenol overdose? What do we teach people when they're leaving the hospital and they're going to go buy some over-the-counter meds, or they're going to go to the pharmacy and go buy some medication? What do you teach them to look for? What is considered the opioid toxicity triad? What are the concerns? When do we give naloxone? When do we give flumazenil? What are the safety concerns with giving them?